So this was a biomechanical study we did that actually we did way back earlier, and actually is some of the theoretical reasons why lumbar disc replacement is potentially better. The arrow, or which one? Next. There we go. So once again, thank you for the invitation. So here comes the boring stuff. So basically, in spine biomechanics, we have 6 degrees of freedom, 3 in translation and 3 in rotation. And as we talked about some of the different types of discs that we have, the semi-constrained ones will allow for rotation and eliminate anterior-posterior translation. In other words, the center of rotation is fixed, and that's like the Pro Disc and Maverick. And the unconstrained, Charité, which is the one that's failed the most, has 5 or 6 degrees of freedom and basically moves too much. Adjacent segment disease is a real disease. I don't think it's symptomatic. Non-symptomatic. I've been in practice now 28 years, and these patients, they come back to you and you scratch your head as to what to do next. So hybrid constructs is a new thing, which may be a medium between total disc replacement and fusion, because some levels need to be fused, and maybe some other levels need to be remain motion. But what hasn't been proven scientifically is, does total disc replacement reduce adjacent segment degeneration? So we designed this biomechanical study to investigate the stability of a 2-level total disc, compare that to the intact spine and a 2-level fusion, and also a hybrid construct, and compare that once again to the intact spine and a 2-level circumferential fusion. So we did some cadavers and we potted them, and we had an intact, we had a 1-level total disc we studied, we had 2-level total disc we studied, hybrid with the fusion at the bottom level and the total disc above, and a 2-level circumferential fusion, which was considered to be the control group. We set it up with testing using 6 degrees of freedom spine simulator with the motion analysis system from OptiTrack. We used 3 infrared light emitting diodes, and they were attached to the front of the body, and they served as a point of motion measurement. We tested each of the specimens with load and unload cycles in the 6 degrees of freedom in terms of flexion, extension, lateral bending, and rotation, and load displacement curves. And the load control protocol was that of goal, and was used to establish intact values, published in 2006. The center of rotation measurement, if you can see the way we measured it here, was that used by Punjabi and Goal again to evaluate the effects of device on adjacent segments. The 3-dimensional rotation was obtained from those little sensors we put, and then with a bunch of complex math, we were able to get the center of rotation measurement for each of the constructs that we did. So here's the results. The center of rotation was preserved in the single level total disc replacement. It was preserved and matched that of the intact spine. In the hybrid construct and TDR fusion, it was close to that of the intact spine. And in the 2-level total disc replacement, it was also similar to the intact spine. So in all of these, the red is the tested and the intact is in white. Here, blue and black. And in here, red and black, so very close to the intact spine. We also did flexion extension, range of motion testing, and we found that the two-level total disc restored motion at L4-5. Interestingly, when you do a two-level total disc replacement, it decreases the motion at the lower level, and it decreased the motion at the lower level of about 16%. But if you look at the adjacent segment, which in this case would be L3-4, there was no significant change in the flexion extension range of motion at L3-4. In the hybrid construct, obviously the fixation one had a reduced range of motion. There was a corresponding increase in the level that had the total disc, and there was only a slight increase in the adjacent segment of about 13% in comparison to the intact. The two-level circumferential fusion, however, did reduce motion at the levels of the fusion, but it increased the motion about 30% in the adjacent level. So biomechanically, the standard of care, the two-level circumferential fusion, the T-lift, the tubular, the MIS T-lift, however you do your two-level fusion, does scientifically increase the incidence of adjacent segment disease, at least in the lab. And it does so by increases the motion at the adjacent level by at least 30%. So statistically, there was a significant increase in the adjacent level motion compared to the intact hybrid and two-level total disc replacement. So the conclusion was that at the level that we put the total disc in, it restored motion. With the two-level, it slightly decreased the motion below, but both levels remained mobile. And in both the one-level and the two-level total disc replacement, they did not change the kinematics of the level above. However, in the two-level fusion, there was a significant, statistically significant increase in the adjacent segment. And in the hybrid construct, it increased adjacent segment slightly by about 12 to 14%. And also in the two-level rigid fusion, once again, it increased the adjacent segment by about 30%. And the other conclusion of the study, based on a biomechanical testing, is that the hybrid construct is also preferable to a two-level fusion. Thank you.
Thank you very much for a very nice presentation. May I ask you one thing, if you don't mind? I was wondering, when you see the increased mobility at the adjacent segment for the two-level fusion, did you kind of infer or consider lordosis when you fuse? Because I always see those studies. We know that alignment is important. Supposedly, with a better alignment, more lordosis, there's less weight bearing on the adjacent segment. How would you explain the, or is there any kind of correlation with lordosis in the fusion and adjacent segment mobility?
We didn't look at that specifically. If you look at the specimens themselves, the lordosis seems pretty matched if you look here on the circumferential fusion versus the other testing. So we didn't specifically measure each of them, but cadaverically, they look pretty similar in terms of lordosis. Because we didn't put small cages in, we put pretty big cages in to sort of make sure that we did have that distracted. We didn't measure it, but that's the picture of the models, so they look pretty lordotic.
But a study can be done to see that lordosis, increased lordosis and adjacent levels.
Sure, you could do the study again and measure each of the lordosis and repeat it, yes. And then, the incidence of adjacent segment is from an anterior approach is automatically less than a posterior approach anyway. So, and the other constructs were all anterior.